Welcome to Health Equity in Focus. This is the Access to Medicines and Intellectual Property podcast of the Third Wall Network, where we share insights and critical analysis from a Southern and equity perspective. I'm Rania De Vito of the Third Wall Network, speaking to you from Brazil. Our conversation today will be centered on the ethical, legal, and equity issues that the Mpox response raises. For today's conversation, we have the privilege of speaking with Chetali Rao, an expert in biotechnology and intellectual property, who works as a senior researcher at the Third Wall Network. Thank you for joining us, Chetali. Could you please first introduce yourself and tell us a bit about your background and experience?
Thank you, Hania, for the opportunity to be on the podcast today. So, I am a biotechnologist and also an intellectual property and trade lawyer with experience in the pharmaceutical sector. I have worked on issues related to drug development as well as on issues related to patents and trade. I am currently closely observing the access issues related to Mpox and the pandemic negotiations. And so, it's a privilege to talk here today on this podcast with you.
Thank you, Chetali. Can you briefly explain about the spread of Mpox, including the emergence of Clade 1b, leading to WHO declaring Mpox a public health emergency of international concern?
Monkeypox is basically an infectious disease which is caused by the monkeypox virus. Animals are generally the carrier of the virus. It was discovered quite early, around 1958, but the first reported cases in humans basically were around 1970. But it was only around 2022 that this actually attracted global attention due to the widespread epidemic which happened across non-endemic regions. It was only in July 2022 that WHO actually declared this as a public health emergency of international concern. Now, the PHAIC was later discontinued as cases started to decline. But since September 23, there have been a lot of surges in the cases that have involved a clade 1b, actually a very new variant of the monkeypox virus. And this has a higher case fatality ratio as compared to the 2022 strain. This is actually the variant that is linked to the current outbreaks in Democratic Republic of Congo and as well as the surrounding African countries. I think it's been reported in 13 more African countries, including Burundi, Kenya, Rwanda, and Uganda. So in August, WHO declared it again as a PHEIC for the second time in 2 years. And I think this underscores the urgency that this situation has actually put the global health structure into.
So I think that leads us to our next question, which is about the availability of diagnostics and therapeutics and vaccines. Could you give us an overview of the landscape of approved and pipeline vaccines and therapeutics for the treatment of Mpox?
So if I talk about the approved vaccines, basically we have three vaccines that are there. One is Jynneos, which is manufactured by Bavarian Nordic, and it is a new third generation live virus vaccine, which is modified from a particular strain called as a modified vaccinia Ankara strain. It was originally developed for smallpox, but is also protective against Mpox in adults of 18 years or older. This is basically administered as a two-dose regimen, and in sometimes in off-label use also, it's been approved in children and adolescents during the outbreak situations where the benefits outweigh the risks. Now, this vaccine has demonstrated an effectiveness, and I think recently it was also pre-qualified by the WHO, thus, I think, facilitating its procurement by international agencies like Gavi and UNICEF. So we also have another vaccine called ACAM 2000. It was manufactured by Emergent Biosolutions, but it was primarily licensed for smallpox. It may be used under Mpox under specific circumstances, but the problem with this vaccine is the potential side effects, which can be serious, especially in patients who are immune compromised. So I think because of the side effect profile as compared to Jynneos, it is not the very preferred option during outbreaks. Now there's another third vaccine, which is called LC16M8. And this is actually manufactured in Japan. So LC16 is also very highly attenuated live virus vaccine, and it was also developed for smallpox. Unlike ACAM2, this vaccine can cause side effects, but it is generally considered to be safer and because of the less serious adverse side effects. The safety profile of this vaccine is especially valuable because it can be used in broader populations like in immune compromised patients. I think, and also because it can be used in adults and children equally, and especially because most of the population that is affected in DRC is currently children. If I talk about the pipeline vaccines that are there, we have two pipeline vaccines called BNT 166A and another is 166C. So both are manufactured by BioNTech in partnership with CEPI. So both of them are multivalent vaccines. One is a trivalent vaccine and the other is a quadrivalent vaccine. And both of them are using the same mRNA approach to Mpox prevention. So currently, no treatments are approved by the FDA, especially for Mpox. There is only one antiviral drug, tecovirimat, which has been found to be effective in treating Mpox. It was in trials in DRC since 2022. And there was a recent news a few months back that it has failed to meet the endpoints against the new virulent strain that we were just discussing in the beginning of the podcast. So this has not been found to be very effective in those cases. Apart from these, we also have two older drugs, but effectively these are the therapeutics and the vaccines that are currently there with respect to Mpox.
Thank you, Chetali. I guess my next question would be if you could comment on the availability and affordability of these vaccines and therapeutics, and also diagnostics for Mpox in developing countries.
There is a lack of access and there is a very limited supply of Mpox vaccines. The majority of available vaccines, such as Jynneos and ACAM, are basically in stockpiles. So they are stockpiled basically with the high income countries like US, Canada, Japan, and European nations. Now, these countries have secured most of the doses, while the developing countries face significant shortages. I think, secondly, another important point is the global disparities in the supply of these vaccines. The inequitable distribution in these vaccines is quite evident because the high income countries, which have the necessary financial resources, are at the front of the queue. And in contrast, the lower and middle income countries often find themselves at the end of the queue. 4 million doses are required to vaccinate the health workers and contacts of the suspected cases in Africa, according to WHO estimates. Now, Africa CDC hopes to vaccinate 10 million people. If you translate it, it could mean 20 million doses because of the two-dose protocol of Jynneos vaccine. However, only 281,880 doses have arrived in Africa by late October 2024. This data is according to the tracker developed by Think Global Health. If you translate it, it will mean that it's roughly 7% of the WHO estimates and not more than 1.5% of what the Africa CDC is actually hoping for. The third point is the extremely high prices. Now, the root cause of all this lies in our reliance on a single company, which is Bavarian Nordic, for the development, manufacturing, and distribution of the vaccines. It is deemed to be the safest and the most effective Mpox vaccine at the moment. This monopoly enables the company to control the supply, the pricing, and that is the sole reason that it's significantly restricting access to this vaccine. The company also does not have a transparent pricing policy. A public citizen study revealed that Bavarian Nordic may be charging developing countries up to 2.5 times the prices that it is offering to US institutions and UNICEF. For example, the Biomedical Advanced Research and Development Authority, BARDA, in the US actually is paying $55.35 per dose, and UNICEF is even paying higher doses at $65 per dose. Media reports say that the international prices for these vaccine can range from anywhere between $100 to $141 per dose. Now, these high prices are difficult to justify. Firstly, because the vaccine was developed using German government technology that was developed in the 1950s, and then it has been heavily subsidized by the US government. Since 2003, the US has provided over 2.3 billion for the development, licensure, and procurement of Jynneos vaccines, while also giving support for clinical studies and also for the establishment of the production facilities. The second comparable vaccines produced in developing countries could cost as little as $5 per dose.
So, Chitali, for our next question, can you elaborate on what have been and are the access needs in the affected countries to stop the spread of Mpox? How have developed countries and manufacturers responded to the needs of the affected countries in preventing the spread of Mpox in Africa?
So, Mpox is basically a story of inequity and neglect. The DRC and other African nations continue to struggle against the spread of Mpox. I think not only due to the severity of the health crisis, but also because they do not have any local vaccine production capabilities. And that forces them to have a long wait for international agencies to buy and distribute vaccines. And I think this situation has actually forced the African governments as well as the African CDC to instead request for donation of shots from rich countries. And I think that system has failed to guarantee timely and sufficient supply. A statement from the Africa CDC a few days back said that 4 million doses have been pledged so far out of an estimated number that they had put forward to 18 to 20 million to vaccinate 10 million people in the next 6 months. The fact is that all the vaccines are currently in stockpiles. So if you read a lot of reports on these, you'll come to know that US has almost 100 million doses of ACAM 2000. Canada also has up to 2 million doses from Bavarian Nordic in its stockpile. And Japan has actually 200 million doses of LC16 according to a report by WHO. So as of early October, according to Think Global Health, of the 5.3 million pledged doses that are there, only nearly 300,000 doses of vaccines have arrived in Africa. So, as we also saw in COVID-19, resource rich countries have rapid access to life saving vaccines, while those that are affected are left dependent completely on pledging donations and foreign aids. No vaccines go to Africa, where the disease is endemic. If vaccines and therapeutics could have been sent earlier, there is a very high probability that transmissions could have been reduced. The mortality numbers and the people affected by the disease could have been much lower.
So, from a scientific and medical perspective, would having WHO stockpiles and providing early access to diagnostics and vaccines to the African region helped to prevent the spread of Mpox?
So while a comprehensive outbreak response is very critical, including various components, we also need public awareness campaigns, we need medical infrastructures, and increasing access to existing vaccines, I think, remains a very pivotal factor in preventing the spread of Mpox. Vaccines are very important not only because they provide direct immunity, but also because they protect vaccinated individuals. And the important part is they also contribute to broader community immunity. But for the vaccines to be effective in curbing the virus, they must be accessible and also strategically deployed in areas where they are needed the most and which are the most impacted by the outbreaks. So, the extremely limited availability of Mpox vaccines in DRC drastically reduced the reach of the national strategic plan for vaccination among Mpox. So, we saw a huge gap between the time the declarations happened to the time when the first shipments arrived in Africa, and still there is a huge shortfall. The problem lies in that when the number of cases went down and PHEIC was called off, no proactive measures were taken at the global level. Most national and global health officials generally moved away from this topic, and also WHO did not work towards creating a stockpile. Probably because also there was no approval for the Jynneos vaccine at that time. It was recently pre-qualified by WHO also. If I talk about from Bavarian's Nordic perspective, also it did not make any efforts to ramp up its production till the second PHEIC declaration happened. Neither, I think, they did not invest in making any efforts in vaccine accessible and affordable in Africa. They did not even share the technology with other manufacturers. So I think these outbreaks illustrate the potential for Mpox reemergence and spread. And I think most importantly, it highlights the limitations in the current vaccine supply and also very timely call for preparedness strategies. So closing this gap actually requires a shift towards empowering African nations with the resources to produce the vaccines locally, fostering, I think, a more resilient health responses.
Thank you, Chetali. And I think this leads us to our next question, which is what role do pathogen samples and sequence data from affected countries like the DRC play in the development and approval of existing and pipeline vaccines, therapeutics, and diagnostics? How are the samples and sequence data being obtained?
That's a very, very relevant question, Hania, because pathogen samples from affected countries are instrumental in the development and approval of vaccines, therapeutics, and diagnostics. We call them VTDs, not only for diseases like Mpox, but also for other infectious diseases like Ebola, for Zika virus, for Nipah virus, etc. So, when you take a pathogen sample, it allows the researchers to perform genomic sequences. These helps us to identify the different strains and the variants of the virus that can come forward. Samples are also very necessary because they help us to identify the potential vaccine targets that we may need to look at. By studying the virus structures and behaviors also, the researchers can determine which components elicit a very strong immune response, and that is how the vaccines can be guided to that particular way. So pathogen samples, I think, are also very, very essential in developing accurate diagnostics. They are also very important in understanding the therapeutic research, in developing clinical trial designs and protocols for the drugs that are under development. We've also seen that apart from the physical samples, or the materials of pathogen, it's also the genetic sequence data that is very important in the development of VTDs. For example, if I talk about Ebola, the product that we have for Ebola, the monoclonal antibody Inmazeb, Regeneron actually developed that monoclonal antibody by exposing the human mice to pieces of Ebola virus. Now, this strain was actually isolated from a woman in Guinea in Africa, and these samples were then taken and sequenced at an institute in Germany. And then these were uploaded on the GenBank database. Now, GenBank is a part of the EU, US, Japanese funded INSDC, which is called International Nucleotide Sequence Database Collaboration. So, Regeneron then what did that? They utilized the sequence information of the Ebola virus. They downloaded the sequence information from GenBank, and then they used to synthesize portions of the Ebola virus. And then this particular monoclonal antibody was developed for Ebola. So, in such cases, we see that there is no need for a physical sample. Only the digital sequence information that you generate, somebody has access to it and they generate the DSI for that and they upload it on the databases. In case of Ebola as well, the sharing of pathogen samples and sequences, which actually contributed towards the development of Ebola treatments in Mazeb and Ibanga, did not actually result in affected countries having equitable access. In fact, this staggering inequity was exposed by the MSF Access campaign in its report also, ensuring access to new treatments for Ebola virus disease, and it was launched in 2023. Meanwhile, rich developed nations such as the US have maintained their own emergency stockpile of Ebola treatments. Like companies like Regeneron, Ridgeback hold almost all the intellectual property to the treatments, also commercially benefited and profited from government grants, tax credits, and advance purchase agreements. Meanwhile, affected African nations that had actually contributed to the development of Ebola treatments continue to struggle to obtain timely access to affordable treatments.
Thank you for explaining this to us. I think that for most people, this is not a topic that we hear about so often. As part of the pandemic agreement, a pathogens access and benefit sharing system, also commonly known as the PAB system, is being negotiated. How would such a system address the challenge of inequitable access?
There is a long history of genetic resources from the global south being plundered and misappropriated by entities. These include both the private and the public in the global north. This has had actually significant implications, including for public health. So, medical products tested, developed, and marketed using biological materials and sequence information from the affected developing countries are often not available or affordable for the developing countries which actually need these products. We have seen this happen repeatedly during health emergencies. We saw this in case of COVID-19. We also have seen this in case of Mpox, Ebola, as I've already mentioned before. During the pandemic agreement, the developed countries actually proposed that countries be obligated to share samples and sequences of pathogens with pandemic potential. This eventually led to calls to establish a pathogen access and benefit sharing system, which is also known as the PAB system. And this is built on international law on access and benefit sharing. This has been clearly set out in the Convention on Biological Diversity, and it has also been further elaborated by Nagoya Protocol. So, establishment of a PAP system can help to address some of the inequities developing countries have actually experienced during health emergencies. Generally, the idea behind the PAP system, as has been proposed by many developing countries, is basically to ensure that recipients of the pathogen material and sequence information are subject to enforceable and legally binding contracts for using the material and sequence information, and also very importantly the commitments towards fair and equitable benefit sharing. Now these legally binding contract actually aims to prevent misappropriation of the shared resources through the patent system and will also ensure fair and equitable benefit sharing. As a non monetary form of benefit sharing, for instance, if a vaccine manufacturer accesses the pathogen material and then the sequence information also, such access is subject to manufacturer agreeing that he sets aside a percentage of the real time production for WHO for distribution based on public health needs. Now, this is very critical so that during any health emergency, the WHO is at the front of the queue in accessing these vaccines, therapeutics, and diagnostics, and its stockpile is adequately stocked. And WHO can then move rapidly to contain the outbreak. Monetary benefit sharing can also help to build up the technological and other capacities in developing countries. So we've had a very good precedent in the WHO for such a system. It is known as the Pandemic Influenza Preparedness Framework, or we commonly call it as the PIP framework. But it only covers sharing of influenza virus of pandemic potential. The experience from this framework, which also implements access and benefit sharing principles, has generally been a good one, with some progress towards realizing equitable outcomes. Unfortunately, in the present negotiations, developed countries are resisting all proposals from developing countries. They do not want to acknowledge the approach taken by the PIP framework. Instead, what they are more in favor of delinking access from benefit sharing, which means a voluntary system for providing benefits by certain selected users. They have also had a very little interest in having a transparent and accountable PAP system, which will then repeat the unjust and unethical equities that we've always witnessed historically.
This is an extremely important discussion, Chetali. Thank you so much. It seems like we will need to do a follow-up podcast on access and benefit sharing. So thank you so much for being a part of this conversation. I've learned a lot. Thank you.
Thank you, Ania, for having me today, and it was a pleasure interacting with you and discussing things with you. Thank you.
Thanks for tuning in into Health Equity in Focus. This program is brought to you by the Third World Network, where we advocate for the needs and rights of the Global South, promoting just, equitable, and ecological development. Hope to see you next time.